and welcome to the Janis Black Warner March January speaker series, our first speaker series of 2024. Happy New Year to you all and welcome. And thank you for joining us. I'm Erin Raftery-Ryan, the Executive Director of NAMI Westside Los Angeles. And like I said earlier, I see a lot of familiar faces, but a couple of new ones. So for those of you who are new, NAMI is the National Alliance on Mental Illness. We are the nation's largest grassroots mental health organization dedicated to improving the lives for the millions of Americans affected by mental illness through support, education, and advocacy. And we are greatly appreciative of all of you being here this evening. If you'd like to learn more about our free programs and services, you can visit our website, which is namiwla.org. I would like to thank our advisory council member, Janis Black Warner. Thank you, Janis, for making this event possible.
Thank you.
We have an amazing speaker this evening, and we're very grateful that she's taken out some time because she's a very busy lady, and she is a leader in our community. She's a doctor of psychology and the acting senior deputy director, Reentry Services Division from the Los Angeles Department of Mental Health. She will be sharing information this evening about the CARE Act, the Community Assistance Recovery and Empowerment Act. The CARE Act represents a crucial step forward in ensuring that individuals facing severe mental health challenges here in California receive the care that they so desperately need. Please join me in welcoming Dr. Jennifer Hunt.
Thank you for my lovely introduction. That's so kind. And hello, everybody. I'm happy to be here and share an update and have a place and space for conversation about care. I think a lot of people are really curious to see what it looks like here in Los Angeles, since we have officially implemented. December 1 has come and gone. And so we have teams in the service areas throughout LA County that are working with individuals who have been where the petition process has started. But for those that may not know as much about the CARE Act, we wanted to have an opportunity to share some of that information here, and then also have a place and space to have questions and conversation. So kind of a combination of little bit of education and hopefully not too much by PowerPoint, but also then time to talk, and then also contact information, since we now have our teams operational and helping individuals all throughout the county. So I was going to share a screen and see about let's see, with Zoom, I apologize. The county uses Teams, so bear with me as I attempt to share my screen real quick. Okay. And sure. Okay, so I'm going to do this in some of this, I will give a little bit of a backdrop and I'll let it run in slideshow mode. Okay. Now, by doing this, I apologize because I can no longer see everybody on Zoom by doing it this way. So, but with that, I wanted to be able to provide a little bit of a backdrop about how the CARE Act here in Los Angeles came to be a year ahead of when we were actually identified in the statute to implement. So this just real quick backdrop is, how did 2024 become 23? And there were a few key events that occurred in December of 2022, with the swearing in of Mayor Bass and Mayor Bass declaring a state of emergency, The county formally supported Mayor Bass's declaration. Then in December of 2022, the Superior Court announced that the courtrooms handling our LPS and AOT cases would be filed and heard at the Norwalk Courthouse. In December, the Board of Supervisors passed a motion asking for us to start planning for the implementation of CARE. And in January, the County of Los Angeles proclaimed a state of emergency relating to homelessness. And 3 days later, and I say everybody, the governor, the Board of Supervisors, the county CEO, our presiding judge of the Superior Court, all parties started issuing press releases talking about their excitement that we would be entering CARE Court in December of 2023, a year earlier than when we anticipated. And I haven't gone through and kind of outlined a lot of these pieces before, formally, I would say, in some of my conversations about CARE. But I think it's really important that we kind of see the bigger picture of the support and resources that we're going toward the concerns about individuals in our community that are unhoused, and how many times when they're unhoused, it's really a symptom of a series of other things and concerns that an individual is struggling with. And so, with that, we, but after getting over the initial shock of, oh my goodness, we're going to be doing this a year earlier, uh, we thought about it and we said, well, would we want to be a trendsetter? Do we want to be a leader? And do we want to show other counties how LA can lead, considering that 25% of the state population is in Los Angeles County? So that's just kind of the backdrop and context. The information that individuals, and I know this is blurry, so I'm going to skip past it. Oh, there it goes. Um, the information that starting getting created with the Judicial Council, the partnerships as we went toward implementation, the information started coming out, and one of which is this 5-minute video that is actually available on YouTube via a few different websites from the Judicial Council, Cal HHS, and others. And it's about 5 minutes and talks about the eligibility criteria for CARE Court. The video was really well done, and actually in the self-help centers in LA County at the courthouses, when somebody will come into the self-help center to seek information about CARE Act, the self-help centers actually prompt this video and have participants or individuals seeking help have them watch the video there, so that it does a very good job of providing context and a backdrop. So just to highlight that here, that that is available and is a very good resource to be able to provide some introductory information about eligibility. For just again to emphasize that this was CARE Court was a civil court process that was established for us to focus on treating individuals with schizophrenia, spectrum, or other psychotic disorders. And that the focus of CARE was to provide behavioral health and housing resources, as well as services, and to protect self-determination and the civil liberties by providing counsel for individuals that are the respondents in this process, and also to help support supportive decision making. The idea was that if we intervened sooner with individuals with services and supports, that this could help individuals in their lives with multiple things and needs. And that one of the big things was the accountability, making sure that we as the local government, the county, and those partners would have the supports, but be accountable for what we're doing and how we're going about providing those services. So the eligibility requirements for those that this may be the first time that you're hearing some of this information, that the individual has to be 18 years or older. So they have to be a chronological adult. They have a diagnosis or they would meet the diagnosis eligibility for schizophrenia and other psychotic disorders, and that they're experiencing symptoms due to their diagnoses, and that they are not clinically stabilized in ongoing treatment. So if individuals are already receiving services, that's not the focus of this program. This is really looking to help individuals that, as a cliche term, are falling through the cracks. We really want to focus on individuals that are not seeking out the services for themselves, but that other people are concerned about their well-being, that the individual's mental health is substantially deteriorating, and that they would unlikely survive safely in the community without the supports, and or they need these services to prevent relapse and deterioration. And lastly, that this is the least restrictive alternative and that they would be likely to benefit from the care plan. The actual physical petition, which a shrunken image of an example on the left-hand side of the screen, that is the technical petition that would be filled out when a qualified party wants to file for the care court petition with the courts. But in addition to that petition, there needs to be one of two things that is provided with the petition. One would be a completed mental health declaration from a licensed behavioral health provider, or evidence that the individual, the respondent, had had 2 periods of intensive treatment, such as the Welfare Institution Code 5250 holds. And it's actually quite specific in the statute that it's the 5250 holds, not a series of the shorter period of time hold, which is the 5150s. And that petitions can be filed in person at Norwalk and at Hollywood courthouses, and that they can be filed in person at any of the self-help centers. And the e-filing option, I need to clearly update the slide. It says future plan, but we have the e-filing option available here in LA County. And help is also available online and in the self-help centers, which we'll talk about. Then this was another, and I'll touch on it briefly. When there are 4 groups of individuals that, or 4 groups of qualified parties that can file a care court petition. And so there's the family home group, there is those are individuals that the person resides with, the person is either related to in some way, or potentially the respondent themselves. The community members, the first responders, directors of hospitals, licensed behavioral health professionals, or directors of public and charitable organizations. And these are all explained also in the video, as well as available from the Judicial Council's information on care. The third group is the county, which is the behavioral health director, public guardian, adult protective services. And the fourth group that could have referrals in or file petitions with care are those in the tribal jurisdictions. And interestingly, we actually don't have any tribal courts in LA County proper, so this isn't something that we have seen in our implementation. The backdrop of this actual form, this was one of our working documents as we were starting to consider and talk about implementation, was that if family members, for example, didn't file on their own to the courts as a qualified petitioning party, how might other questions come up from the referring parties or groups within our community? So the boxes above or below were some of our brainstorming about who and how would we potentially be receiving forms from, or inquiries about the referrals into care court. So that's kind of just a behind the scenes item. And that's why a lot of it is written with all of our county lingo and acronyms and different things, because this was one of our working documents. But I wanted to just kind of highlight that we were and continue to consider all the different ways that we may be engaged or asked to help an individual that might be eligible for care court. So this is our, I guess I can officially say, famous workflow. Um, so thank you to Jean Ho at the CEO's office, who brought this statute and workflow to life. Jean's vision and ability to put this together visually. Not only did this create the platform for Los Angeles and our blueprint for our implementation workflow, but actually this was adopted by the state and is actually in some of the official documents that you will see online. And that's what we kind of are going to be walking through. So what happens is that there's 4 phases to the care court process. The case gets initiated, that's the first graphics. Then the next section with the arrows moving from left to right would be about the assessment. The third is the determination and treatment order. And then the fourth would be the treatment implementation and court oversights. So with whether the entry is a petition that's filed by DMH, or if the petition is filed by the other members of those qualified groups, either way, the first step is that a prima facie determination is made. And the judge reviews the materials that have been provided, which is the petition and one of those 2 supporting documents, and it is reviewed. If the petition was received by somebody, was written or filed by someone that's not DMH, then the court was handing those over to DMH to investigate and create a review and recommendation. Does this individual meet criteria? As you'll see on the bottom, the timeline, these are all the different requirements set by the statute from the time that one activity occurs to the time the next activity shall occur. So from the time that the determination is made to the time that, for example, DMH receives that information and is to investigate and provide a report back to the court, that's 14 court days or 28 court days if we are ordered to produce the report. With those documents, then the court determines to proceed, whether or not to proceed forward with the case. If there was someone other than DMH who brought the petition to the court at that initial hearing, then if it proceeds forward, DMH is the responsible party to be responsible for all the subsequent court deadlines, the timing, the reports, and to keep track and scheduled with the statute. And so as the case would potentially go through those different places and spaces, that's where the different elements of the court of the statute would come into play. At the initial hearing, that's also the opportunity for the original petitioner to share their concerns, share why they brought the petition to the court, and that is where the individual, the respondent, would have the opportunity to, with their attorney, because they are offered and appointed an attorney for this process as well, to be present with their attorney and share whether or not they want to participate in the process, and also to share if maybe they are actually participating in treatment that maybe individuals don't know about, or also to talk about why we all would be there to talk about why we're concerned about the individual and what we'd like to do to be able to help them. And that time whether it's the initial hearing or right there with the hearing on the merits, this is also when the idea of a supporter would come into play. And that a supporter could be somebody that would be able to assist the respondent with some of those different types of decision making, as well as helping them walk with them through this process and help advocate and support their decisions related to treatment. So, with that said, I don't want to go into the weeds of the legal process, but I just want to kind of back up a little bit and just highlight that as you go through different phases and stages, it as soon as we start meeting with somebody, we're going to be offering different types of resources and supports. The first is connecting with the individual and also introducing what some of the different features and possibilities that partnering, working with us in DMH, technically becoming a client would what would that do and how could we provide support and resources between therapy, housing, other social support connections, and also with, conversations about medication. Now, while we may offer those things and propose those things, it's ultimately up to the individual to choose if they want to participate. So we can have all those elements offered in a care agreement, but whether or not the person agrees to it, ultimately they still have that decision making power and choice. We hope that over the course of time and working together that maybe they would be open to hearing about some of the different options related to treatment or some of the services and supports. Um, while right now, since it's been only a month into the implementation, we're still in the case initiation, assessment, and early determination phases. So we can talk about that later, maybe during the Q&A when people are saying, what does it actually look like now? So but one of the things that has come up in many different conversations and places and spaces is the fact that this whole process is voluntary. And while we really want to encourage people to participate in it, it is voluntary. And if someone decides not to participate, that is ultimately their choice. And so I really hesitate to say that somebody failed out of the process because to me that implies that um, there this was a voluntary process. So how can you fail at a voluntary process? So I've really just tried to be neutral and say that if someone isn't participating or they choose not to participate. And so if we do have individuals that choose not to participate, then that's where we can talk about some of the other options and resources that we would be offering individuals. Also, there may be individuals that um, family members refer or some of our partners in the county or in the community refer because they think they would be good candidates, but maybe they don't actually meet this program's criteria. So it was very important for our director, Dr. Wong, and for our entire implementation team with the county that we had just as solid of a plan to provide support to individuals that were not eligible for care court in one way or another, but that we would be able to have them somehow access the resources and have available to them the other types of programs within the network. So this was our visual example of this. So with our individual who is walking with the literal missing piece to the puzzle, um, we wanted to talk about what some of the more restrictive programs are, all the way through the least restrictive programs in the outpatient setting. So for individuals that have been hospitalized under the WIC 5150, that's a locked setting in the hospital. And so if you were to go one step to the left, that is a locked facility that is only accessible when it's under the LPS criteria. When you look at all of the options to the right of the 5150 LPS bubble, those are all voluntary programs. And the gradations as you go from crisis stabilization into the outpatient realm is, for example, at the hospital, all the services are provided to the individual in a locked facility. As you continue to move to the right and you go into less restrictive, then housing and then programs all become less and less dominant, but the individual is participating and going toward the services more so than when the services are um, in a facility. So, for example, ERS, CRTP, as just two examples, those are housing dominant programs that have mental health services. As you go and home team with our homeless outreach mobile engagement that is focusing on individuals that are chronically unhoused. Those are our field-based teams that are going and looking to find individuals that are um, unhoused, often in the streets and in encampments. And then as you continue forward, you have AOT, which is assisted outpatient treatment. You have care. You have our FSP, full service partnerships. And then you have our outpatient treatment, ultimately going to the clinic based version. What's interesting and special about Care Court is that Care Court is open to individuals that may have commercial non-Medi-Cal insurance plans. And this is a very, very unique thing in the CARE Act legislation, because in other programs that have been offered by DMH, you either have to have no other commercial insurance, no other insurance provider, or you would have eligibility for Medi-Cal. And so CARE is unique because it was the decision was made that they did not want insurance to be a barrier to accessing this level of care and this type of treatment. So this is, again, a very unique piece. With full service partnership, which some people may know by the I'm going to say brand name FSP, the full service partnership was part of the Mental Health Services Act and Prop 63, which was now, oh my goodness, almost like 20 years ago. I think it's a little more than 20 that it's been on the books. So with full service partnership, these are field-based services and they provide a higher level of care than what would be offered in a outpatient clinic where the client goes to the clinic to see the providers. In the managed care plans, the majority of the services that are offered are only under the outpatient treatment clinic office-based service model. So with the county, we are fortunate that we have many things that are above and beyond just a clinic office-based setting. So we highlight this because we want to show that if some individuals are not eligible for the CARE program exactly, there are many other services that we want to make sure that they have the opportunity to access. So these are the focuses of our graphic. The I'm gonna, so one of the focuses that made our Care Court implementation here in Los Angeles unique is that from the beginning, we conceptualized and wanted to make sure that peers were involved in creating as well as producing, implementing, and as part of the actual teams that are in the field providing services when once care was implemented. And so there was a lot of research done because we were considering initially putting together an innovations project through MHSA. And ultimately, we didn't feel that that was the most effective resource because we could actually potentially bill for the activities of the peers as members of the team. And so the innovations dollars would be better served by innovative programs that wouldn't be able to seek reimbursement. But as part of this creation and part of our implementation team, this was a significant piece that in every step of talking about how care would be implemented, talking about how we would create the teams, talking about what roles and what providers would be most appropriate, best suited, how would we have these teams constructed? We had employees with DMH with lived experience in every single meeting and in every level of decision making regarding this. And so there's a great amount of pride and distinction with this, because this, to our knowledge, is a distinct element of our implementation compared to other counties. And who's to say that maybe as that trendsetter, being the trendsetter of LA County, hopefully maybe in the second cohort, as we get other counties to join in the subsequent calendar year and fiscal year, that maybe they would be taking our lead and looking at hopefully a lot of the success that we feel will come from the outreach and engagement provided by the peers that are on our teams. My lights went off. I apologize. I'm going to wave around. I'm here in the office and eco-friendly mode. If I sit still too long, it lights turn off. Sorry about that. So this is a big, important part of our care court implementation here in LA. And in this, I'm I apologize. I'm not able to select out the certain slides without in this view. So I wanted to talk about this graphic.
Jennifer, I think we can hear you if you wanted.
Can you?
Yes, we can hear you.
It's telling me you can't. It told me that my phone doesn't allow me.
Well, we do hear you, but maybe it's a
Okay.
good time to transition to more of a conversation.
Yes,
Great
because
idea.
apparently my entire the internet at our actual DMH headquarters has gone completely down. So
Oh my God.
I know, right? So this is why I came and did the presentation here at the office, so I would have stable internet connection. And here I am on my phone at the window. So I apologize.
No,
And I
bless you
appreciate
for being
everyone's
here.
flexibility. So I will, yeah, but it's telling me my Zoom won't allow my video on my phone to work. So you may only be getting audio of me right now.
So maybe
I apologize.
Maybe you want to have Dick start with his question.
The video.
Dick, did you have a question for Dr. Hunt?
I did, thank you. Are we, can you hear me?
I
Dr.
can hear you. Can you hear me?
Yes, we can.
Yes.
Oh, okay, yay.
Thank you very much, Dr. Hunt, for your presentation and going through all this chaos of in and out of the internet. So, here's my question. And
Sure.
I might be jumping way ahead, but so my question is, this is voluntary. And,
Yes.
and most of the people that I work with and a lot of the people in NAMI families have is family members who end up on 5250s and they get discharged before they're stable. They're discharged to unstable placement. They go AMA. They end up getting hospitalized or 5250 or 5150 and then 5250 again. They get discharged again and their placement is not stable. They're non-compliant, which is the medication non-compliant, treatment non-compliant, which is the reason that that an individual, my estimation, would be applying to the court for the CARE Act help. So is there any point along the line when you're working with the voluntary situation and you have a plan and the individual continues to be non-compliant and not willing to work with the resources, but continues to deteriorate and becomes, more acutely ill? Is there anywhere along the line that it pivots to an involuntary situation or could pivot to an involuntary situation?
And do you mean an involuntary situation as in would the team be able to have the individual go back to the hospital, or are you directly referring to something toward conservatorship and
Both.
LPS?
Both.
Okay. Okay. So let me address they're distinctly different, and one we do have some ability and one we don't. So I do want to be clear about that. So if an individual that we are working with as part of the care court process and team, if they are in crisis, our teams are LPS designated. The clinicians have the capability to make that evaluation and have an individual go to the hospital under the 5150 process. So just because they're participating in care, it doesn't mean that individuals don't have crises and need a higher level of care at any given time. Just like someone may not be a member of the care court process and they may need the evaluation of a 5150 for involuntary hospitalization. So that is available to the participants, and the clinicians do have the capability to do that. On the other side, looking at the more the longer term LPS distinction and moving toward the conservatorship path, care is not connected to that. So the care court process is entirely independent of the LPS conservatorship investigation and process. The one crossover piece, and I think this gave a lot of people concern in some groups initially, because they felt that this would be a way that people's rights could be potentially taken away, was that in the care statute, it states that if somebody wasn't successful or did not complete the care process, that if they fell out of the process per se, or just discontinued participation, that information could be used up to 6 months as evidence that the least restrictive option was not available. But it's used as evidence. It's not that it would trigger or create the investigation for LPS. And so for some individuals, even just the prospect that this information could be used for some groups could be distressing. But for some groups, like what you're describing, I think that this could also be a point of frustration for people, because they're feeling that this is a voluntary process, and if they're not able to participate, then there should be more of a connection when there's not. So if an investigation is initiated, that hasn't changed for LPS. That still has to occur through one of the progression after the person's been hospitalized. So that determination for an investigation still starts there. The difference is if they haven't participated in care, that information can be used as part of the evidence in that investigation, which demonstrates that they're not able to participate at a lower level or in the least restrictive setting. Does that kind of make sense, how the two are connected, but they're not?
Yeah. Yes. Makes total sense.
Okay.
Makes total
Okay.
sense. I don't want to take up a lot of time. I just had one quick question.
Sure.
How many applications have you had since you started the court in December here in LA County?
34 petitions through today. And that's from December 1st through today. I counted right before I came onto the call because I knew that I would get asked. So the minus the few court holidays, we saw a handful of the petitions come through in the first week or so. And then with a lot of the holidays and the courts being closed, for select days, as well as New Year's, we have seen a lot more petitions in the last few days. So we think that there will be more petitions as the holidays are now over, and a lot of businesses and things are picking up, and people are done with the holidays. Let's just put it that way, in
Mhm.
more ways than one. So
And how's it going with on the applications, either the 100, the declaration, the psychiatrist declaration, or the documentation of hospitalization? How is that working? Because I would assume in most of these cases, the person being filed on is not going to consent to information being released. How are you handling cases where petitions are being filed, but the individuals being filed on are refusing to have the information released?
it hasn't been about the information being released. What's been, I think, what we've seen is that family members have gotten very creative about the records that they have kept, and meticulous about the they've and this is, I think, all to the credit of groups like NAMI that have advocated for families to have really thorough records, and their chronicle, a timeline chronicle of events, because some petitions have had that type of information, and that has been accepted by the courts. So I think it's about, some have produced, there's been a variety of documents that family members have had in their possession that they've legally had, that they have shared with the court. The one thing that I do want to share is that the information that is submitted with that petition is available without any redaction to the respondent, to the potential client. So whatever family members submit to the court, pictures, evidence of any sort, notes, we have seen a lot of different things. Every single item is given to the respondent as part of that petition. So I think this was one of the things that our teams have been, and we're going to be talking with the self-help centers about, because we don't want individuals thinking that that information is only going to the judge. It's actually given to the respondent because legally they have a right to see those documents that are filed. So there's been times where we were asking, especially if this could potentially be concerning, that the individuals see those records. So we're having conversations about that, but this is something that they are able to access. So I think that's a really important piece of information that, in the theoretical implementation didn't come up in conversation and in reality. So, and some family members have been concerned. They've shared that at the self-help centers, that they're concerned that their loved one would see those documents. They could be possibly very emotionally triggering, right? So we are very aware of that, and we're trying to see what we can do in a legal but clinically empathic, appropriate way to address that.
It's great. Is everybody able to be as delicate as you are about going through every case like this, or are you starting to get real busy in your office? How is it going?
This is a very important piece to me, because we have a lot of team members that have a lot of passion and a lot of excitement, and they've shared their own experiences. Half our team members have lived experience, and that was a big part of what we wanted to. So they were upset when some of the individuals took the documents and kind of threw them back, or when some of our teams have gotten chased and by some upset individuals. And so we've spent a lot of time having conversations about that. And, you know, they've said, okay, Jennifer, you know, what do we do if this happens? And so we spend a lot of time, not only, fortunately now we have our, you know, amazing team of supervisors on board, and our teams are now in those service areas, but there's a lot of conversations that are had about this. So I feel this is really, really important. And I have obviously the backing of Dr. Wong, and this is how we're leading by example, right? So if we don't have enough individuals, you know, if something were to happen and all of a sudden, okay, well, how do we cover this or cover that? I've gotten on the self-help phone line and answered the kiosk myself, and as have the other supervisors and managers, because that's how we do things. We do things to make sure that we're focusing on the clinical needs of the community. So, you know, it also gives me an excuse to have my field-based attire back on, and I get to go back out into the field again. You know, I don't have to be in the stodgy, you know, business attire all the time. I was today, you know, to be all fancy for this, but, you know, but otherwise, you know, we really want to just make sure that um, we're there for the right reasons. And I was sharing, I said, I think Aaron gave me a great frame for it, was that our teams are just so passionate to help. And they've identified strongly with a similar named mascot in the community, and they've dubbed themselves the Care Bears. And so they see themselves as a very caring group of individuals that want to just go out and help people. And, you know, please, none, you know, if anyone's a lawyer and works for whoever owns the Care Bear trademark logo or whatever else, please don't get me in trouble for that. But I'm just saying that they want to represent, and they see themselves in a very positive light. And that's been, I think, a big thing that we've had people come away from administrative jobs and say, I need to go back into the community. I need to help people. I want to be part of Care Court. And virtually our entire implementation team, even though they were a cross section of the department at large, a good majority of our implementation team, if they were working for another program, have ended up coming over to Care Court full time from the time they started the implementation last January to present day. And so I think that really speaks to the way that we've built it and the way that we feel about it, and how we have the buy-in from the community, and community being the DMH community, of we feel responsible for helping create it. And so we want to be part of it.
Great.
I have a question, if possible.
Go right ahead, Debbie.
Okay, thanks. Is this, it's kind of going opposite what Dick was saying, but like, say a loved one volunteers and says, I will be part of Care Court. Could it be a bait and switch situation where the judge says, oh no, you're going into the hospital. You're going into a 5150 or 5250. Could that situation occur?
Not to my knowledge. And this is why, because the Care Court statute, unlike AOT, does not have a caveat where it can compel the hospitalization for an evaluation purpose. So
Okay.
And that I can just speak to that piece. And like I said, while we as clinicians within the program may have LPS designation and have the ability to utilize or have to look at a crisis safety plan, including hospitalization involuntarily, everything that we're doing is to hopefully avoid that and keep individuals in the community connected to their supports and resources in a healthy way.
Right, because I mean, I know hospitalization is a lot of times traumatizing for people. So,
Absolutely.
you know, and I think that's why they would be willing to do this maybe instead, knowing that they're not going to be, immediately called off to a hospital. They're going to be able to work with you.
Right. And that's the goal for us, is to work with individuals in the community. And there are ways too that, and we've already looked to explore this in a few situations, that if a petition is filed, which it was, and we went out to meet the prospective client and they said, well, I'm okay working with you. And that kind of came as a surprise to us. And we were like, wait, what? But,
Yeah.
right. And so they met with the team and they were following through what they said that they would do, and vice versa. And so we can continue working with that individual, and we can actually request that the petition be dismissed, and we can continue our work with them without having the court involved at all. And it's actually considered part of the statute under what they call a voluntary status. So we do have ways that we can continue to, even though it started as a court process, make it a non-court process. So,
Right. But if it's all
I think
voluntary,
it's
it's voluntary.
mm-hmm,
So if
right,
you meet
right.
someone and they say no, thank you,
Mm-hmm.
how do you go from there?
My answer is relentless engagement. So if they say no, thank you, then we'll try again. We'll come back another day. We'll come back at another time. But we're going to continue to try to build a rapport and engage. Even the individual that chased us down the street to make sure that we got in our car and left, we still went back at another time to try to engage them again on a different day, and maybe that, we'll do it a little differently. Or maybe if they know that we talked to the person that filed the petition, okay, well, maybe we won't, mention that person this time, or maybe we'll go without that individual. We actually are also, we've been embraced by the lawyers from the bar panel that are representing the clients, and they want to come out with us, which was the whole intent of this, to make it a real collective, very cooperative, positive interaction. So that's
thank you,
what,
Jennifer. That sounds it's amazing. It's amazing. And you're so thoughtful with your responses. And we can actually, I can visualize the work that you're doing just because of your thoughtful responses. So thank you so much. Cynthia, I see that you have your hand up.
Jennifer, thank you. I have a question. A lot of the family members that I have with NAMI,
mm-hmm,
they have children at home, which are like in their
yes,
40s and 50s, and the parents are seniors, and they're very
yes,
frightened. They won't go to a doctor. They
yeah,
will not take medication. Are you think in
mm-hmm.
the future you'll see teams coming out from DMH? I mean, these people would be homeless. They're delusional. Would you have teams going and knocking on doors and becoming friends with these individuals that are scared and bond together a trust eventually?
So Cynthia, just help me understand that the older adults, the caregivers, are the ones that have reached out for
Yes.
connection. Okay.
Yes. That have the
So
connection with their child living at home with them, that are in their 40s
mm-hmm,
and 50s.
mm-hmm,
And it's they're not taking medication. They're
yes,
afraid to go to the doctors. I have several, and they're
mm-hmm,
not listening. They're not talking to the parents. They're texting the
mm-hmm,
parents, or they're violent with the parents. It's
mm-hmm,
no problem, smoking marijuana and
right.
getting very ill. And the
Can I speak?
parents don't know what to do.
Can I
Yeah.
speak to that? Because I'm in the same situation, even though I'm a little bit younger. And
Mhm.
I'm not saying, I'm saying that I set boundaries, and my son would be homeless if he wasn't on medication. And
Yeah.
that's the truth. And I said, you can be homeless or you can be on an injectable. And
Mhm.
that's it. And you got to hold those boundaries. I'm sorry.
Mm-hmm. Well,
I think the question though, is perhaps
how do we get
because
help?
the like your teams are going back to people, from my understanding, that are homeless, or you see them in
Mhm.
communities and you
Right.
continue to go back. I think Cynthia's
Mhm.
asking if parents reach out and
Mhm.
they, well, will you go to homes
Yes.
and start to have that relationship?
Yes. And so, Cynthia, my answer to you would be that, you know, you can, if they don't feel comfortable going to the court and filing the petition, then the email that we shared earlier, the care court at DMH, and that can be one of the ways that, if you, with their consent, if you were to give us contact information, or we can provide a phone number and you can give it to those community members, those parents, those caregivers,
Mhm.
then have them call us, and then we can send teams out. If they want us to come to their home, we can do that.
That's
And
wonderful, Jennifer.
yeah,
That would
so
be so
that's
beneficial.
the informal quote unquote route. So while we are the ones that file the petitions in the county, we had made the agreement, and I feel so bad that the internet literally went down,
Mhm.
and I wasn't able to share parts of this, but, and that you all, we got disconnected and I didn't even know at first. Thank you, Erin, for calling me. But the we are having that route of the referrals by our colleagues in DMH, or by Adult Protective Services and other entities within the county, but as well as the community, that they can reach out to us and we can explore and meet with or talk to potential community members to see about eligibility or just services in general. It doesn't have to be care court. That was the whole point. It's that there's no wrong door. And that if somebody reaches out and they happen to have a need that doesn't fit into the care court, quote unquote, program, we're not going to just say, oh, sorry, you're not eligible for care. We're going to be like, okay, what can we do? How are we going to do this? And that's where our partnerships and our relationships and our other resources within DMH come into play. And a lot of us had, we have substance abuse counselors, senior community health workers, we have medical caseworkers, we have psychologists, we have a lot of different individuals that have different roles within DMH that come from programs. They have housing expertise, they have knowledge of DPSS and what's necessary for eligibility. I won't say poached because it sounds horrible, but let's just say that magically we have a lot of people that came to care court that used to work at DPSS. And no offense to, sorry, DPSS, but we have some awesome people. Thank you. And we have some resources, that we have a broad group of individuals that can help in different ways, and they know about many different programs and many different things, and they speak many different languages and come from many different backgrounds. So
Jennifer, before the evening, can you please
Mhm.
give us that general phone number?
Yes,
I
we
would really
have,
appreciate that.
yes, the main avenue right now is the care court email, because since we already have teams in the different service areas, I would rather see where they are and have them connect to the actual service area. But otherwise, the general number that was given out during a lot of the press events was my office number, because we didn't have a number yet at the Norwalk office, which I'm happy to give because it's on every presentation. So if individuals are ready, it's my office number, but it's the number that Camille assists with. So it's a good live number. It's 213-947-6614.
And Camille was lovely, Jennifer.
And
Thank you.
yes,
Can I have
yes,
you
and
talk
that's
about the
why we can.
peer, the Medi-Cal peer support for the family
Yes,
members as well?
yes, yes.
Thank you.
So with the Medi-Cal peer support, we have a lot of peer members of our team, but we did not want to make it that you had to be Medi-Cal peer certified in order to be a member of the team. We wanted people to have the experience potentially of working on the care court team and use that as the application and the work experience to apply for the certification. So we are not, we want to see that, we want to be able to have individuals that are certified via SB 803, but that is not a requirement in order to come and join us as a member of the care court team. So we don't have anybody certified to date on the team, but I feel like, well, billing, the billing is not our focus. Our focus is making sure that we're getting help to people who need it. My boss may not like that answer entirely, but I know she supports that. So about my negative billing comments, but
Jennifer, what I was trying to say is that if you become a Medi-Cal peer
Mhm.
support person, that was
Yes.
like the 80 hours that you take to pass the course,
yes,
then they are able to get a payment to help.
yes.
How much are those payments going to be?
Oh, that they get the payment, or you're
Yes.
talking about the
The
matching
peer, the peer that's working,
but the peer would be the peer is an employee.
right?
Yeah. So you're saying that there's
Are
an
you the, is
additional,
it the employee of the DMH?
yes, we've been,
Okay.
that was part of, my understanding is that in order to apply and go through the process for the SB 803 peer certification,
Mhm.
that there's work experience that's necessary in order to apply. And so what we did when we created the positions, we didn't want to make it a requirement that you already be certified, because how would you potentially get the experience in order to apply
Right.
for the certification? So we see that as an aspirational goal of the program, to be able to get individuals in to be employees and then help them pursue that certification once they have the work experience. And the work experience is the work of care court. But we didn't want that to be the requirement, because we felt that that created a barrier to getting people the experience they need in order to apply for the certification. And now that we have a peer chief, Dr. Robinson, Tony Robinson, you know, then this is where the exciting work goes about what other ideas Dr. Robinson has in mind about peers within the department and how we can expand their roles.
So it was my understanding, if you go into the CARE Act program, you will be
Mhm.
assigned a peer to take you to your doctor's appointments, take you to your treatment.
That, yes. So that is the supporter role.
Right.
So that is somebody that's independent of our DMH members.
That's what I'm trying to say.
Okay, I'm sorry.
It's
And
okay.
so yes, so they refer to that through the CARE Act as a supporter, the supporter role.
Okay.
So the supporter is somebody that can, like you just described, work with the respondent, be there step by step. But what we were concerned about is that individuals that often are untreated with schizophrenia and psychotic disorders are often really isolated, and they may not have somebody easily identifiable, or they may not want the individual potentially who filed the petition to fulfill that role. So that was also one of the thoughts behind having a large amount of peers on our team, is that we may get a lot of people that just don't have somebody in mind that could be a supporter for them. But if they have one, then absolutely, once it's defined about the information that they're able to have access to and their role within the team, then absolutely we want to use that person in that role to build their social network around. But we're just concerned that a lot of people being so isolated may not have that, especially at the beginning.
Makes a lot of sense.
Yeah. So that's why. And
What I'm saying is if you're on the streets, you're homeless, there,
Mhm,
and we finally get my daughter or my son into
mhm,
CARE Act.
mhm.
And I have another son, and that son could be with him as a peer supporter,
Sure.
right?
As long as that's granted by the client. Yes.
Okay, and there's a fee that that person gets.
That I will have to check on the fee part.
Oh, I would like to know that. Thank you. We've been
Okay.
in a program every Wednesday or every
Mhm,
Tuesday for a peer court. And it's really, really very informative. We're in with a lot of other NAMIs, but a lot
mhm,
of the stuff is still, I know, because it's just the beginning. We are doing our
mhm,
first step and we're trying very hard. But these are the things people say, like in San Diego County, they don't get peer supporters. I was told in LA County, we will have peer
mhm,
supporters. So
mhm.
we never know. And that's what I was asking.
And I apologize because we often use terms interchangeably.
Right.
And so I apologize if I perpetuated or created some confusion around that. So for when I was referring to the peers as DMH, those
Right.
are our employees that are team members, but I will find out more about that, Cynthia. And I do know that NAMI's been involved at certain levels, and I can't recall which parts of affiliations related to training and some of the work to help with the supporters. I know there's been many groups that have been involved in either providing trainings or having individuals that may be able to fulfill that role through the CARE Act.
Thank you, Jennifer.
Of course.
Could anybody apply for SB 803 certification? How would one do that if they were interested in that?
They can do it, I believe, independently. There is a link in the and there is actually an application process, and I would have to go back and actually look at, I know I have it bookmarked, but there is a formal application, and that's where that so many hours of work history and service comes in. And I believe there's also some coursework. Oh, there we go. Erin, I think, just dropped it in the chat. So it, yeah, of course. And I know that there were some fees and there were some scholarship programs to also grandfather in and recognize certain types of work. I don't know if that period is over, but again, we're looking at trying to reduce any barriers for individuals to seek certifications and increase their employability. So, but I know it's come up a few times in conversations with some of my colleagues at the Peer Resource Center downstairs at our headquarters. We have a PRC in our building here at headquarters.
Jennifer, does anyone on your team, do you offer a psychiatrist? Because, for instance, I know a waiter at a restaurant and he's Latin and his son is psychotic and lives with him. He can't keep a job. He's always, he'll work at a sandwich place for a week and then he quits. So the parents were going down to Tijuana and getting medication, psych meds, and mashing it up in his food without him knowing it. And he was functioning quite well. And he asked me if I knew a psychiatrist, because he doesn't have a lot of means, that they could go to. So what is your advice? Because his son is now willing to take meds, but they don't have the means for a psychiatrist. And where would they go?
One of the places that they could go is the urgent cares. And yes, we're in the process of hiring psychiatrists, as well as we have a few nurses on board already, but we are in the process of hiring psychiatrists. There, within the county, we do have the urgent cares, and some of our other field-based teams have psychiatrists that are in the field as well. For your specific situation, that would be, I think, they could bring the prescription from Tijuana and show the doctors at the urgent care what the person is currently taking. They could also, depending upon geography or other specifics, we can connect if you want to kind of spell out some specifics about geography and some other details. I know this is being recorded, so I'm just trying to be respectful of not asking for personal details on,
So could I give them your number and you
Sure,
could
and give
dot
them and the email, and we have many Spanish speaking clinicians and team members that would be able to connect with them. Yes.
And also, can we NAMI members give you resources that you wouldn't even know about? IOP classes for psychosis. Dr. Wexler, UCLA, my son's psychiatrist has a program that's it's an IOP in West LA only for psychosis. And they teach them tools to use. For instance, if you go into a Starbucks, they learn you're going to have a lot of voices, but they only have to listen to the barista, for instance, or they teach them tools to live. And I think it's one of the best programs I've ever seen. And my son is doing quite well, but a lot of people can't afford it and they don't have insurance. Would you pay for something like that? In addition, would you get means from the government to pay for people willing to go get tools?
That's a really interesting question. I think it would be great if you could share the contact information, because there may be other ways that program could be accessible, and we're always open to gathering resources and making those available and making sure that our teams and communities can access anything that is possible, right? This is the organic part of how do we make, we have them making resource binders, we have them going to different meetings and different places within the community. So I think it would be great to have one of our teams just go see that just for their own eyes and to see how that's happening,
And also law enforcement, how do you educate law enforcement or the police and fire and about what you guys are doing? And what is the difference between a pet team and you? I'm a little confused.
Sure. So, old school definition of the pet teams was that they were affiliated to either a designated facility or program, and we still refer to them that way, honestly, at times. But the idea of a psychiatric mobile response team, a team that could go into the field and conduct those types of evaluations, that is a capability that many of our field-based teams have. Whether or not it also depends upon like where the call originates or what is the request. So for example, FSP teams have individuals that can conduct those evaluations, but the calls or their service is generated by the caseload of that program, rather than being on call and being dispatched or deployed across the county from the 24/7 helpline number. The field, the whether it's home team, AOT, care court, we all have members that have the capability to conduct those 5150 evaluations and an involuntary hospitalization. Does that help give some distinctions to the? Okay, no problem. I know I don't want to speak in acronyms, and so I want to just make sure that that information is helpful in that way. And the urgent cares too can also initiate that involuntary hospitalization.
How if they don't have insurance? I don't understand.
Because we have designated resources for uninsured community members. Yeah.
Erin, I texted you California on Track, the information, and if you could, Erin's very good at tech.
Certainly. Dr. Hunt, thank you so much. You've been so helpful. And Cynthia, I see, are you trying to get your hand up? Is there another
Because
question?
Lynn had her hand up.
I was gonna say, I
Oh,
think, yeah.
I'm sorry, there was one more
Sure. I'm
person. that
sorry,
had a
go right
question.
ahead.
I just had a really quick question. Thank you, Dr. Hunt. It's been really informative. I was just wondering whether your teams would be trained or able to help people with things like applying for disability.
Yes, so some of our team members in their previous capacities in other clinical programs had helped individuals with SSI process. And they're one of the, I think, benefits of having a lot of psychologists on the team is that we are able to do those SSI applications and evaluations and help with some of those facilitating things like the application for a disabled transit pass and some of those other features. So it's been a minute since I've looked at the SSI from the professional signatures side, but those things are things that our clinics do and that we would have either the capability or help facilitate. So
Great, because I
Yeah.
understand it very hard to really get disability, and so obviously knowledge of that process is very helpful.
Yeah, and unfortunately, with a lot of federal programs, there's a lot of red tape that goes with it. But the fact is that we have team members and case managers and medical caseworkers that are versed in and have helped advocate and navigate and go with the client and support them with navigating that process, whether it's DPSS and benefits, or if it's other federal level benefits to support people.
Thank you.
Oh, of course. Thank you
you
for
question.
your accommodation of my technology going completely kaput during this process. So
We're so grateful that you scooted back on. And I wanted just to give an opportunity for one of our team members, Oshri. Oshri, I don't know if you're there. I sent a message via the chat. If you are, please come on, because I wanted him to share a specific
I'm
story.
here. Yes. Hi.
Yeah, great. Yeah, if you
I've been
could
here.
share just
Yeah.
a brief intro about what your work with Cal Hope and your outreach here with NAMI West Side and the experience that you had at the Santa Monica Library.
Yeah, I'd love to. I'm Oshri. I'm one of the Cal Hope outreach specialists. And it's been a really great job objectively, but I also know this is a long meeting and I did want to share that story. So, and also thank you again for your presentation and sharing with everyone what's going on. And yes, so through NAMI, I'll jump into this story happened at one of the many outreach events that I was doing at the Santa Monica Public Library. We had a few there, and you could tell, it wasn't like light traffic. It wasn't heavy traffic. But you could tell a lot of the people coming through, there was probably a pretty profound need, I would say. Not a few people appearing homeless coming through the library, and you can feel it was really just a safe, clean space. And anyway, I was there with my colleague, Jared Bendifola, and there was a young man who came by our table, and I think he grabbed a sticker and he said, sorry, I can't chat longer. And said, no problem. Okay, we wave, we have these mental health stickers that we give out as part of the resources we have at the table. And then a few minutes later, the guy came back and said, well, can you guys take me to the hospital? And we said, well, I don't know about that, but I can try to find a close one, and direct you to one you could walk to nearby. And I started looking on my phone, and it all kind of unfolded at the same time. We said, well, what's going on? He said, well, I'm feeling really depressed, and I'm out of my, he said, I'm schizophrenic and I'm hearing voices. I'm out of my medication. And we said, well, okay, let me, and as we're still looking for a hospital, thinking what to do, he said, I don't even know if I can walk. My feet hurt. And he said, can you guys call the police for me? I'm feeling suicidal. So, Jared and I looked at each other, said, sure. So I called 911 and explained exactly the situation. And you couldn't imagine a sweeter person, like just in need of help and knowing what he needed. And he said, they said, well, what does he want? Does he want us to put him on a hold? And I looked at him, do you want them to put you on a hold? He said, yes, please. And they said, okay. And I said, I was very clear many times that he was, about how gentle and sweet he was, I guess, because of all of my predisposed biases about if they're sending police over to the library for someone who looked like he may be homeless. So anyway, they said, well, they'll send someone over. They couldn't promise the amount of time it would take, but ended up being pretty quick, actually. And we pulled up a seat for him next to the table. And I gave him while he was waiting, I gave him a copy of a book I wrote called Stay Alive. And he just kind of read that very sweetly and quietly. And it was really quiet, except one part where he laughed really loudly, and which was good. I was glad to hear him laughing. Police came. It was two police women showed up, and he actually saw them near the door, and I walked over and guided them in, and they asked him a few questions. It was pretty simple from there. Asked if he had hurt himself that day or hurt anyone else. No. And they walked out, and it was, and they all walked out together basically. And as he was passing me by, he turns and he looks at me and he says, thanks, Oshri, I'll remember you. And it was, it was a really rewarding moment, and it really made a lot of the work we've been doing feel very worthwhile. And also it was one of those moments, it was like, wow, there's been so many worthwhile moments, but it's like, wow, if that was the only worthwhile moment that I'd experienced, then that would have been something I really treasure. So yeah, it's been really good to have a presence in areas, communities, and places where you can just feel the need is strong. So that's my story. Yeah. Thank you, Erin, for letting me share that.
It's beautiful. Thank you. You touched all of us. Thank you.
Yes.
I want your book.
Oh yeah, let me know.
You should get it.
Yeah, it's called Stay Alive. You can find it on like Amazon. But yeah, it's called Stay Alive by me. And that's actually how we connected, Erin, originally, because I wanted to share that. Well, I'll go into it. Well, since you mention it, and as like the web of life would have it, I connected with Erin about that book, And the reason I connected with Aaron, who guided me to it, was the counselor of my brother, who I hadn't talked to. My brother passed away about 9.5 years ago. And someone, there's been, I think, a few people here familiar with conditions of like self-medicating of marijuana and aggressiveness at home. And that was a situation my family was well, not unfamiliar with. So no, a lot of my love for him went into that and other projects. And I reached out to, anyway, his counselor, who I know and hadn't talked to in years, and he said, well, you should reach out to NAMI. And so basically that's what brought me to this moment in a nutshell. So thank you. Thanks for letting me share.
Thank you for sharing, Oshri. Thank you so much. We're so grateful for you and the work that you do and to have you as a part of our community. So, and thank you for sharing, because I really did want to kind of highlight some of the work that NAMI does, and really that, if you weren't there that day, what would have happened? We don't know. But just as we move forward with the CARE Act, I think that NAMI is an integral part of that equation. And we welcome suggestions and ideas from DMH about how we can continue to partner and really make those connections and be in the places like the public libraries where there are safe spaces where people maybe go to find that additional support. So, anyway, thank you again, Oshri, for sharing.
Thank you.
Dr. Hunt, do you have any closing words? And we just appreciate you so much. I know it's about 8:40. We're going about 10 minutes over. So, and it's getting late, but if you'd like to have any closing remarks. Oh, there you are. There you are. You're moving now. But you're on mute. One more step.
It is a good thing you didn't hear me say anything bad. When you told me that, yes. So here we are, successful, hopefully all the way around. Maybe not. But just thank you for the invite. And I think that the more, any opportunity to continue to partner in any way, shape, or form, I think is really kind of our approach. And we're led by Dr. Wong and her embrace of doing things differently and just really trying to connect with the community and be good partners, So thank you for having me and the opportunity to come and meet with all of you and spend time with you all this evening, and whoever may see the recording. And yeah, I'm just happy to be here. So
Thank you.
Thank you very much.
You.
Levon, I see that your hand is up. I think we were just kind of closing. Is there anything that we can support you with?
I've had the MET team out for my daughter, who is 41 years old, within the last 2 weeks twice. She's schizophrenic and on and off fentanyl. She just got home from detox on Saturday, but then she just now got herself all prettied up and just left and said, if I'm not home by 9:30, I'm not coming home. I don't know if she's going out to prostitute herself or whatever. She got her EBT card today, so now she's got some money. I'm beyond myself. I can't have her here because I have her son, who I am raising and have legal guardianship of, and I have to protect him from her. Adult Protective Services was at my house today, and when there's a call that goes out to Adult Protective Services, Child Protective Services gets called too. So now we're going to have Adult Protective Services for the way that she is mistreating me, but now they're going to accuse me for not protecting him. And she just comes and goes whenever she wants because we don't really lock our door. we don't really want her living here. St. Joseph called and said that she had placement and was going to get housing as of today. I heard the conversation, and yet St. Joseph's didn't call all day today, so she's without a place to stay. She's been homeless for a year and a half. Met team said that they were going to refer me to the Department of Mental Health when they were out here. Two lovely ladies with very similar names. And but I haven't heard anything from the Department of Mental Health. Can you shed some light on what I can expect? Because I can't have her around because of the 10-year-old boy. And she is very abusive to me. Thank you. Any reactions?
That's a lot of things going on. And I'm glad that you either called or someone called the Met team, and APS and DCFS both as county partners. I think those could also be some good supports and resources to programs to keep you and your 10-year-old, family member together and supported, and maybe help also with other supports and resources to, as another person had said earlier, about the boundaries and helping you as you shore up those things to be able to address your daughter, So I'm happy to also, we can try to, connect offline, because we do work with Met. If you want to send information either with the phone number that you received from me or the email, and we can also follow up with the Met team and circle back with them on our side if you would like that. But I won't do that without you saying that. But you're muted.
You have
You're
my
muted.
permission. You have my permission. You have my permission. I'll put my phone number right here, right now.
No. I mean, can you also, I think those are all different parts.
Dr.
That
Hunt, you're
calls for
offering
concern,
some,
and that
you're going in and out just a little bit. I think you're offering great support, and perhaps would the best way for Levon to communicate with you is to call your office in the morning?
Yep, that'd be great.
Okay, Levon.
Thank you.
And Levon, too, you have support with NAMI, support groups, things like that. We're here for you. Okay.
Yeah.
Okay. Well, everyone, thank you so much, Jennifer. It was such a pleasure. And you navigate with such grace and thoughtfulness with every response. And I know that your team is bringing that to their work as well. So thank you for being here this evening, and thank you all for staying so late and just being a part of this. These are wonderful speaker series. And again, thank you, Janis Black Warner, for allowing us to create this space for everyone. So
thank you, Erin. And thank you, Dick, for filling in when Jennifer went out. And thank you, all of you, for being here tonight. And let's keep doing this because it helps all of us. Thank you.
Wonderful. Have a great night, everyone. Thank you.
Bye.
Take care.